Dr. Law, thank you for joining us.
Thank you so much for having me. I really appreciate the opportunity to be here.
Good to have you here. It is Sickle Cell Awareness Month. Mm-hmm. Tell us about that condition.
Sure. Sickle cell disease is an inherited red blood cell disorder that results in the formation of a crescent-shaped or sickled-shaped red blood cell.
I'm sorry, they're supposed to be round.
They're supposed to be round, nice and round and concave, but as a result of a genetic abnormality in the protein that binds to red blood cells called hemoglobin, the red blood cells become very, very sticky, and they assume this crescent or sickled shape. The result of that is that hemoglobin cannot help with delivering oxygen to tissues. These sickled cells get stuck in small blood vessels, which starve tissues of oxygen and cause ischemia and damage to organs.
People who have heard of sickle cell are probably aware that it's largely a black disease. I mean, to what degree is this within the universe of people descended from people from Africa?
Absolutely. The persistence of the sickle cell trait has occurred because it offered some protection against malaria. So we tend to think of sickle cell as a black disease in the United States, but worldwide it affects many different ethnicities. There's a large Mediterranean, Saudi, Yemeni population, and that overlay seems to correlate with the malarial belt around the world.
So within your practice in Baltimore, what's the patient demographic like?
I'd say the majority of patients are African American. We have a small percentage of patients who are also Hispanic who are affected by this disease.
And for this to be passed on, it's genetic.
That's correct.
It's not something acquired.
No.
So it's a gene that you need to get from your mother and your father.
That's correct, yeah. It's autosomal recessive inheritance. So you have one copy from mom, one copy from dad, and the result would be an affected individual.
Affected to what degree?
It can vary. There are 4 different genotypes of sickle cell, all of which can be associated with a number of disease-specific complications. The hallmark of the disease is this what's called vaso-occlusive pain crisis, so patients who can present with very severe intractable pain that requires IV pain medications and usually an admission to the hospital. But there are a number of head-to-toe complications that can be end results of having this disease.
How often does the patient who comes in with that kind of pain, those complications, how often do they know they have it?
The majority of patients who are presenting to the hospital are aware of their diagnosis, absolutely.
How about the trait? I mean, how many people who are, I suppose, carriers, is that the right word? How many folks who are carriers are aware that they are?
Yeah, 1 in 13 African Americans in the United States are carriers of sickle cell trait. In 1975, New York started the first newborn screening. Since 2006, all 50 states have had newborn screening. So majority of patients are usually aware of their trait status, but certainly we always encourage people to get tested. It's a very easy blood test, simple to do, and it becomes especially relevant if people are thinking of having children and they may want to have their partners tested to see what's the risk of having an affected offspring with sickle cell disease.
So what's the difference between sickle cell trait and the disease?
Yeah, sickle cell trait, you only make about 50% of this abnormal hemoglobin or sickled hemoglobin. These individuals do not have the characteristic pain crises and don't have end organ damage that we see in sickle cell disease. In sickle cell disease, you're making pretty much 90% to 95% abnormal hemoglobin or sickled hemoglobin. You don't make any normal hemoglobin.
So how can you help folks? And how much has that changed over the years?
I mean, certainly individuals with sickle cell, I think they are beset by 3 problems. One is accessibility. A number of these individuals require subspecialized care and should certainly be plugged into a hematologist or an internist with some expertise in sickle cell. Access to care can be really challenging. Most of those providers are located in urban centers. So if you are living in the Eastern Shore or Western Maryland, you may have to travel many hours, and you may be getting local care with providers who are not familiar with the disease. 2, this is an under-resourced patient population, so certainly anything that one can do to help advocate on behalf of these individuals is very important. And 3, many of our patients encounter some degree of stigma when they go and present to EDs or hospitals in terms of getting the necessary care that they require.
Remind our viewers, if you have a question about sickle cell disease, you can send us an email to livequestions@mpt.org. The average patient, what degree of limitation on their daily activities do they have?
Yeah, it really varies. I mean, individuals with sickle cell disease do have a compromised mortality, so their life expectancy is about 30 years less than unaffected individuals. On a day-to-day basis, it really depends. Some patients live with chronic pain, which can impact their ability to do usual day-to-day activities, can impact their ability to work. Patients can develop respiratory and cardiovascular complications, which can cause trouble breathing, chest pain, difficulty with exertion. Patients can develop chronic joint pain, so they often develop what's called avascular necrosis of their joints, requiring joint replacement surgery, usually at an early age.
What's the edge of therapy these days? What's new? Where's it heading? I mean, I've read about genetics. About bone marrow. What's the most dramatic tool in the toolkit right now?
Right now, the mainstay of treatment is an oral medication which is called hydroxyurea, which was shown to have significant efficacy in patients in a large study from the mid-1990s. That's our disease-modifying therapy. There are several other therapies that are available that impact elements of the disease, but just like you touched upon, in 2025, we certainly want to have a more definitive therapy for sickle cell, and so that consists of 2 options. One is called bone marrow transplant, and then the other is what was recently approved by the FDA, which is called genetic therapy. That uses the patient's own cells to correct the abnormality that causes sickle cell. Patients receive chemotherapy and their own cells are reinfused back into them, go to the bone marrow and start making non-sickled cells. So it's very exciting. Yeah.
You've seen it work?
It is a very new technology. It has a long lead time in terms of identifying the patient and bringing them to that technology. So at University of Maryland, we're working with 2 patients right now who are in that process. And so we hope to be able to infuse them their genetically modified cells by 2026.
How about transfusions from just regular donor blood?
Absolutely. Many of our patients rely on regular transfusions to help prevent or mitigate the risk of developing complications related to their sickle cell. So all the more reason for people to advocate as well as to donate. You asked, how can people help? Certainly being a regular blood donor, especially if you're an underrepresented minority or URM. Those individuals are very underrepresented in our donor pool, and that would be a great option if you wanted to support patients with sickle cell disease.
What would improve access to care? You mentioned that the population that gets this may be under-resourced, may not be in Baltimore City with the tertiary care medical center and the subspecialist. How can we help people better?
I think one is for patients to just recognize that they need to be seeing a subspecialist. Many patients are just acclimated to the status quo and maybe haven't been told that it's important for them to see a provider who specializes in this disease. Once patients are referred, we can kind of take it from there. We have a lot of options for telemedicine, so patients don't need to travel all the way to Baltimore to get access to care. We can put in care plans so that their local hospital knows how to best treat them. We can be a resource for patients if they're ever admitted locally, so that we can provide them with the best possible care, even if they're not necessarily at our hospital.
With a large patient population, a lot of research being done, what makes you hopeful about the future for people with this condition?
I think there are a lot of reasons to be hopeful. It's great for us just to be talking about this and recognizing National Sickle Cell Awareness Month, knowing that there are several options for definitive therapies for patients and that we want to be seeing people at the University of Maryland and we want to talk about how to connect them to care.
How difficult is access? You're booked out 6 years or no?
No, definitely not. We're happy to see anyone, and we would love to have patients join our clinic.
In the half minute we have left, let's focus in on the idea that blood donations, routine blood donations, are really important and help people directly.
Absolutely, they can be life-saving for our patients. And
we think about donating blood in terms of people with emergencies. This is a chronic condition. where there's a constant need.
Constant need. So yeah, it doesn't have to be a donation, doesn't have to be an emergency. You can just go out and contact the Red Cross and travel to your local donation center.
Dr. Jennie Law with University of Maryland Greenebaum Comprehensive Cancer Center. Doctor, we appreciate your time. Thank you very much.
Thank you for having me.
Your health segments are a co-production of Maryland Public Television and the University of Maryland Medical System.